Dr. Ujiki, welcome. And obviously we're here in Houston, NBT, and my understanding is you're here today to talk about the Pope procedure. That's what we'll be discussing.
That's right.
Can you just, assuming that I'm just your regular general surgeon out in the real world, how would you describe this procedure?
Well, the Pope procedure, Pope stands for per oral plication of the esophagus. So we're actually going through the mouth non-surgically, and we are plicating or narrowing, if you will, the esophagus in patients who have a very dilated esophagus that's not emptying well. And we haven't really had great options for those patients in the past. They were pretty drastic options. Things like removal of the esophagus was our only option, and that's a pretty drastic option. But now we can go through the mouth with a very simple outpatient procedure that really doesn't even require much of a recovery and is pretty effective.
And can you kind of walk me through the procedure?
Yeah, so it is under general anesthetic. The patient is laying supine. We go through the mouth, and we go in with an endoscope with a suturing device that basically allows us to plicate or suture the esophagus so that it's narrower. So patients with certain diseases, like for example achalasia would be the most common, the esophagus becomes very dilated and becomes very tortuous, and food can get, or liquid can get hung up in the esophagus and not empty well. And those patients have aspiration pneumonias, they have pretty significant dysphagia, they lose weight. And they really can't thrive well. Their quality of life is very poor. So by going in and suturing the esophagus, we take the tortuosity out of it, we straighten it, and the esophagus empties much better.
Have you guys seen any specific problems or postoperative complications with this procedure that would be specific to this procedure?
Yeah, that's a good question, and we've been very excited about it. But like any procedure, there's always, potentially some issues or complications. We're fortunate that the complication rate is actually very, very low. But the one issue that we do see is that there are some people that need more than one session. So we may suture the esophagus and they may have temporary relief, but after a few months or a year or two, either the sutures wear down or something happens where their symptoms start to return, and sure enough we confirm with an x-ray that their esophagus is back and dilated and tortuous. We haven't had to do it more than twice on anybody in our series, but we have had a handful of people that have needed more than one session. And I'm sure as time goes on and our series expands, there'll probably be some people that need it even more than twice. This procedure is so well tolerated that I really don't see any harm in having to repeat it if it does need to be repeated. So that's the one thing that we've seen. We really haven't, fortunately, had any bleeding complications or perforation complications. So certainly, I'm sure those things could happen and probably will one day, but they probably will be very low rates of those kind of complications. But I do think that the surgeons that are performing this procedure need to set the expectations with the patient that you may need this more than once, but that's okay. It's an outpatient procedure, takes less than an hour, and it's certainly better than the alternatives out there. And it will improve your quality of life. We see significant improvements in quality of life after the procedure.
And when you say improvements in quality of life, what does that look like?
Well, they can swallow better. When one can't swallow well and they can't eat well, that really is a difficult thing to live with. So when people are afraid sometimes to go out to eat because they're afraid that at any time they can spontaneously regurgitate in front of people. So taking that away, allowing people to socialize better, eat better, gain weight. Obviously, when you can gain weight, you feel better. When your esophagus is empty, you sleep better. So those are the kind of things that we really see. So people sleep better, they eat better, and with those, a significant improvement in their quality of life.
And as you pointed out, esophagectomies, they come with their own complications. Some are quite morbid, and even mortality is definitely associated with it. So I would agree with you. I think that if you have to repeat this even 5, 6, 7 times in the course of 30, 40 years, it sounds like there would be a much better procedure to offer the patient than to go through even one esophagectomy.
No question. We started doing this procedure in about 2018, I believe, or 2019, and we have not had to do an esophagectomy since we started doing this procedure. And I treat a lot of achalasia patients in my practice, and it was very common for us several times a year to have to perform an esophagectomy in patients with end-stage achalasia, and we haven't had to perform one in 6 to 8 years. We haven't had to do it, And I think, and we're seeing more and more achalasia patients. So you would think if this was not working, we would have to do that. But we've been very fortunate. And I think, as you said, I mean, that's a high mortality, high morbidity rate procedure compared to others. And being able to avoid that, I think, is a big, big win.
I have one more question for you before we wrap this up. I think in the news, and of course, everybody's talking about GLP-1 inhibitors. Where do you see that in the algorithm with bariatrics?
I think that's a great question, and we talk about it every day. I would just say that obesity is a lot like other diseases that we treat. Take, for example, stomach cancer or gastric cancer. Gastric cancer, you have a better chance of curing or controlling that disease with multimodal therapy. So chemotherapy first, then surgery, then more chemotherapy. We don't tell a patient, you should either choose chemotherapy or surgery. We actually give them both, and they have better outcomes. So I think we should, as surgeons, not be concerned that maybe our volume will be affected. I think GLP-1s are great. They're here to stay. We have a target. It's only going to get better. Once you have a target, the drugs are going to get better. There'll be less side effects, maybe less frequently needed. And I think medication in addition to surgery or endoscopic procedures is where the future is going to be. And we're already starting to see hints of that. Research out there showing that if you combine therapies, if you have GLP-1s and surgery, you have better outcomes than either alone. Why wouldn't we want that? Why wouldn't we want to attack a very difficult disease, a chronic disease, one we probably don't really ever cure, we just control it? Why not do everything we can to do that? So I like the GLP-1s. I think they're the best thing to come around in a long time. I think, we have to work on expenses for patients. We have to work on coverage, of course. But I think together with surgery, we're going to see really good outcomes, better outcomes than we've ever seen. And I'm excited for it.
Dr. Ujiki, thank you so much for your time. It's been a pleasure, and I hope you enjoy the conference.
Thank you so much. Appreciate it. Appreciate the time.
Oh, no, thank you for being on the cutting edge.
Thank you.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. SurgeOn, where surgeons go to explore, discover, and learn.
Time spent charting is time away from patient care. That's why we created SurgeOn Scribe. With one click, generate complete soap notes and save 6 minutes per patient. That can add up to saving 2 hours every day. No more late nights documenting. With a simple setup and customizable templates, you're ready to go in minutes. Start your free trial today and transform your workflow. SurgeOn Scribe, because your time matters.
Welcome, Dr. Filicori, to the cutting edge. This is NBT, SAGES NBT down in Houston, and we're here to discuss AI in surgery. Tell us a little bit about what you're talking about here at this conference.
Yeah, this is a very special week. We've been holding this AI digital session for 5 years now. And we were amongst the first in the country to generate this kind of content around surgery and procedural medicine. And together with Eric, every year we strive to bring the best content to our viewership and our surgeons. And AI has really taken over many aspects of our lives as a surgeon, from the video aspect, the procedural support, all of the preoperative risk management, and so on. And so every year, new applications for this technology come up. And we want to be always able to deliver the best possible to our SAGES members.
I have to say, I've been excited about this conversation all day. My understanding is you are the expert at the intersection between surgery and AI. And of course, right now, AI is the talk of the town. That's what everybody in the world's talking about. And you have the best understanding of how these two things really intersect. Can you break it down a little bit and walk me through, as a surgeon, what should I see or what am I expecting over the next 18 months to 3 years from the world of AI and how it's going to start to influence the day-to-day work of a surgeon?
I think a lot of opportunities will come to the surgeons to engage in the use of AI. Definitely the procedural skills analysis that AI can bring will be one of the main topics. Help with any aspect of the life of a surgeon, including help with writing patients' notes, calculating the risk of a surgical procedure based on that actual specific patient, automated dictation of procedural notes, automated billing, increased safety in the operating room by way of improving the quality of the timeout, decreasing the number of never events, and so on. Increasing operational efficiency in the operating room. As we know, the operating room is probably the most expensive place in the hospital. 60% of the expenses of a hospital are generated there. And really managing the block time in the best way possible, it's paramount in order to decrease the expenses of a hospital. And AI, through the calculus capabilities, including deciding whether a surgeon is likely to leave his block or not show up or not fill the block, for example. Those are all use cases for AI that can really increase the operational efficiency of a hospital.
One of the first things you mentioned was basically procedure evaluation. So you're talking about looking at the surgeons, how they're doing actually in the procedure, and then showing ways they can make it more efficient, more safe. That's actually something AI is going to be capable of doing?
Yeah, so there are several research labs looking into this right now. There's several companies that are looking into this right now. We also have some of the biggest robotic players that are looking at the data that is generated by the robot and potentially associating that with surgical outcomes. We are still at the beginning of this, and every year we get more and more use cases around understanding how the surgical videos or the data from the robot, which is called kinematic data, is associated with how the patient is going to do. But we can already determine whether a patient is going to have a complication. For example, if a patient is a lot more likely to bleed postoperatively, if the patient is more likely to stay in the hospital for a longer period of time. And as our data collection capabilities grow bigger and bigger, and our ability to associate different data streams, so the video, the kinematic, the data from the electronic medical records, as we get better at associating all of these data streams, so will grow our capability to predict the outcomes of a patient and the performance of a surgeon.
So basically, the more information we have, then the ability to determine all these outcomes. So right now, I mean, as a general surgeon, I'm really looking at a few labs, or I'm kind of trying to get an idea, general gestalt, if this patient's good. And we have, historically, we've had the ability to run through certain algorithms and kind of get a general idea of risk stratification. But you're saying AI can pretty much stratify anybody, correct?
Right. So, I mean, this has been the year of multimodal AI, right? We started off a couple of years ago, we started getting ChatGPT. We got all really excited. ChatGPT is very good at taking text and giving you an answer. But this year, a lot of companies have truly pioneered how to ingest multiple layers of data, including the video, for example, the text, tables, the audio. And, when it comes down to risk prediction, obviously the gold standard for us surgeon is the ACS NSQIP risk calculator, which is based on hundreds of thousands of cases. But the variables that you get in the ACS NSQIP calculators are still just a subset of the actual complexity of the patient itself. They don't take into consideration, for example, the preoperative imaging, the CAT scan, how difficult the surgery is going to be, and all of these other variables. And as we get better and we are able to feed all of these variables into a model, our ability to really predict how difficult the surgery is going to be and how well the patient is going to do will increase exponentially.
One last question. You're immersed in this field. What excites you the most when you sit down and you think about it and where this is going to go in the next 3 to 5 years?
I am really excited around understanding what happens during a procedures in terms of data, right? Quantifying a procedures in numbers, in functions, in models. Quantifying the surgeon's performance in a way that then the surgeon can gather feedback in order to become better, become more proficient, and so on. So in order to do that, we're going to need to integrate a whole lot of different data sources in the operating room. The video, the kinematic data source, the patient data, and so on. So I am actively involved into creating a pipeline so that all of these data sources get conveyed into the same data set, so that we can potentially use them to provide feedback to the next generation of surgeons.
No, it's very impressive. I thank you so much for your time, and thank you for coming on the cutting edge and continuing to do the work. It's amazing. So thank you.
All right, beautiful. Thank you.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. SurgeOn, where surgeons go to explore, discover, and learn.
Time spent charting is time away from patient care. That's why we created SurgeOn Scribe. With one click, generate complete soap notes and save 6 minutes per patient. That can add up to saving 2 hours every day. No more late nights documenting. With a simple setup and customizable templates, you're ready to go in minutes. Start your free trial today and transform your workflow. SurgeOn Scribe, because your time matters.
Dr. Hiles, welcome. Glad to have you here at the NBT here in Houston. So today I'd just like to talk to you. You have a pretty broad and long history working in the medical device companies. And also, I think you were the inventor of the SIS technology as well.
Yes.
Can you kind of give us a little background and how you developed that and why you got into the field?
Well, so medical devices versus biologics versus drugs, it's a whole different world in the FDA and regulations and things. And medical devices are interesting because they can be plastic or metal, or they can be made out of biologic materials. And so I was doing my PhD work at Purdue, working on materials that we thought would grow with the patient, and we were working on vascular grafts and tendons and ligaments and all kinds of different things until we got into the more regular general surgery type things like hernia.
And my understanding is back in those days, the FDA really didn't know what to do with your device, correct?
Yeah, I think that's a good way to put it. As a matter of fact, the gentleman who was the president of our company, when we went to the FDA for the very first clearance, and we were trying to get a clearance for wound care, the FDA asked, "What's in it?" And his answer, after a little bit of pause, was something like it would take half the gross national product to figure that out, but it's acellular, it's been guaranteed to be disease-free, that kind of thing. So we were able to convince them that there was nothing harmful in it.
Do you feel that we really understand all the complexities of developing a new surgical device? Or what would you consider to be the major misconceptions you typically deal with when you're talking to surgeons?
Well, obviously some surgeons understand it because they work closely with industry, but I would say one of the major misconceptions is that it's easy to do and that it's quick. Very seldom is it quick. The design engineers spend a lot of time trying to get the particular needs of the clinician out, and if they don't start there, then they're likely to design something that doesn't work or doesn't meet the need. But they also spend a lot of time doing what we call verification and validation testing. So you go through this whole process of design control, and you figure out what are all the specifications and how tight do they need to be, and how big in this, how big of that, and what's the package need to look like, and all those kind of things. So they spend a lot of time on the details, and sometimes too much until they get good clinical feedback.
I would say a misconception on the surgical side. I was working at some of the institutions I've been at, and they were very hesitant to allow us to discuss anything with industry or have those kind of open conversations. And I always felt that it was a roadblock to our ability to really innovate, because in my opinion, the engineers really have to have that open dialogue. I mean, we're the tip of the spear per se, but without the engineers and the developers behind us, we wouldn't have any of these products. As an engineer, what did you see as the most common problem you had when you were having discussions with surgeons? I mean, do you feel like they were open with most dialogue, or do you find that sometimes it was difficult?
If they were at large academic institutions, and at the time, you know, I think the pendulum, like anything else, swings back and forth, and sometimes the institutions were very wary of industry and their influence, but for the most part, we could get good time, but that actually was the problem, was getting time with the surgeons and finding out whether we could get a little bit of time to explain what we were trying to do, what we were trying to meet, whether we were making sense or not from a surgical perspective. But perhaps another one is the understanding of, because I was working with biologic materials that work with the body and not against the body, that they are different. And one of the complaints we always got was our product goes away. And we're like, well, yeah, but that's actually part of the benefit, not part of the problem. It's part of what makes it work.
I know when I was still in the research world, I had the opportunity to sit down at a table with numerous hernia surgeons when another company was bringing out a device that also went away with time. And that was probably 15 years ago now. And at that time, it was the same argument. Everybody's like, well, I don't want something that goes away. But now you look at the modern realm, in the modern world of surgery, it seems to be where everything's going. I mean, the push is really to not have a permanent piece of plastic. And of course, you were at the cutting edge of doing that. Mm-hmm. Do you think that the surgical world has finally started to turn the corner and that we're seeing the benefits of basically tissue regeneration instead of just pure plastic? Or do you think we're still kind of in that bubble where permanent is good?
Well, I like to think that we're making the turn, but I'm not quite sure because there's lots of resorbable polymers out there, so those go away. But there's really two things to think about: is whether it resorbs and goes away with time, but also does it build up the tissue or not? And you have to get both of those. So you need something that stimulates the body to regrow tissue at the same time that it's going away. And that's the hard part. And that's why natural tissues come into place, because the best biomaterials from scratch, synthesizing engineers can't figure out exactly how Mother Nature does it. So it works better to start from natural materials and go the other direction. So,
I think my last question is on the lines of, it's more general. In my experience, a lot of medical professionals have this belief that the industry is out purely for financial gain. And I do know that, I mean, every company is out for financial gain. However, in my experience, I've always felt that my interactions with industry, their engineers, the developers, everybody that's kind of working, it always to me feels like they really are trying to create something that's best for the patients, really to try to help surgeons accomplish their goals. Was that, I guess I'm kind of leading you a little bit, but was that your feeling, or do you feel that there is very much a balance between that and then people that really are out for money? I mean, do you think that, where do you see the device industry, generally speaking, from an ethical or moral standpoint?
I think it's a broad spectrum. I do think that there are companies out there that are really out for the buck, and if they can't make X number of percentage every week or every month on a product, they're going to drop it. But there's also a lot of other companies at the other end that really focus on the patients, and if we happen to make money, or if we don't make, if we don't make it nearly as much money as we could, that's okay because we're focused on the patients. I like to think that's where I was going with my company, was patients first. We use that as a metric every month. How many patients did we treat? Perhaps to our own fault because we weren't making a lot of money. But the downside of that is that there's a spectrum. And I do think that there's room for both. But in the world where payers pay everything, then it becomes either, fighting over price or commodity products that you can make very cheaply. So that doesn't help technology. There really needs to be a way for new technologies to get some kind of a leg up or a benefit in the reimbursement world and in everything, at least for some period of time, until somebody else can come along and say, okay, I can do this faster, cheaper, whatever, but still treat the patients.
Well, Dr. Hiles, I appreciate your time. Thank you so much. I hope you enjoy the rest of your time here in Houston.
Yeah.
And maybe it'll warm up a little bit for us.
I think it will. It's supposed to be warmer.
Thank you.